So my name is Joanna Masel. I am actually an evolutionary biologist by training originally. And when COVID happened, like many people, I looked for something useful to do, and I understood probability and I understood exponential growth and had a number of skills. And actually my PhD was in infectious disease, and I've always been a modeler. So I looked for something useful and quickly found this. And basically, let's hang on, oh, here we go. Okay, so why exposure notification apps? So I'm not going to explain what they are and so on, because I know this audience all knows that already. So I'm going to talk about the why and what good is it instead. And I think the things that people have previously focused on have been yay for privacy preserving. That's what has motivated a lot of us. Epidemiologically, super important has been speed. This is an illness that's incredibly hard to manually contact trace in time, and every day you can gain in the contact tracing process is an enormous victory, even if it's exactly the same people you reach. And scalability in places that have large numbers of outbreaks, manual contact tracing is quickly overwhelmed, and electronic solutions can be scalable. So I think there's been a lot of emphasis on those three things, and they're all true and they're all great and they're all important. I want to sort of just compare other things. What you lose, of course, is a person. A manual contact tracer can explain, they can coax, they can hopefully get somebody to quarantine, which is super important. And this is one of the reasons these strategies need to be complementary, not alternatives, that it's very important to channel people to manual contact tracing one way or another, so that they can get the help that they might need if they want to quarantine and it's hard. There's also been a lot of focus on who is reached, whether it's strangers or people without smartphones, that it's not always exactly the same population available. But the part I'm really going to be focusing on is the ability to gauge, who is risky enough to tell to quarantine. So manual contact tracers, they can use a lot of judgment. There are rules, but in real life, they do use judgment, and they ask, is something face-to-face? Is something indoors? Were you wearing masks? And they decide, if they've got some huge list of contacts to follow up on and they can't get to all of them, they won't get to all of them, but they will triage and they will get to the most important ones. And apps can do, and it's a very informal process in general. Apps have other things available to them. They do not know. App does not know whether you're face-to-face, does not know whether you are indoors if you're using the current GAEN protocol, and does not know if you're unmasked. But phones are very good at telling time. So you do have a stopwatch. They're very good at remembering what day something happened on. And they're not limited in computation in any meaningful way. So they can use a complicated algorithm that wouldn't be viable for a manual contact tracer. So I know most people have been following sort of, some sort of official guidance on who should quarantine. And so the WHO originally came out in a paper a long time ago in a different world that was explicitly had in the context of containment in its title, a situation we are definitely not in. And they said 1 meter face-to-face 15 minutes was evidence enough for close contact. In Europe, that was expanded to 2 meters, face-to-face for 15 minutes. In the US, for some reason, 6 feet's about 2 meters, same thing, but the face-to-face got dropped out. I have absolutely no idea why the face-to-face was dropped out, but it was part of the definition. All these definitions also include people in direct physical contact for any period of time. And in Europe, they also include those who are in shared indoor spaces, since we now know this is an airborne transmission route, and there really isn't any magic about 6 feet. So my concern, so here's an article I wrote with the ethicist, Peter Singer, and he was extremely concerned both about the actions of public health authorities and about the actions of Google and Apple in terms of doing a poor job distinguishing which contacts are likely to be infected. When you recommend quarantine for somebody, that's basically telling them for up to 14 days to go into voluntary house arrest. There are ethical obligations that come with the psychological anxiety, with the potential loss of income, with the logistical inconveniences, you know, that we should take very seriously and take as a responsibility to discriminate greatly and not just say, okay, we traced contacts, but figure out, you know, what the risk of those contacts are to the best of our ability and target this. So the CDC guidelines, you know, are made for manual contact traces. In practice, you know, what it is it's a binary. Are you 6 feet? Yes or no. Are you 15 minutes? Yes or no. Was it from 2 days before symptom onset to whenever the, you know, at latest 9 days after symptom onset? Yes or no. And if it's yes, 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 you're a close contact. And if, you know, but if you are 7 feet for 8 hours, right at the peak of infectiousness, it's a no, according to the CDC guidelines. Now, that may not be what manual contact tracers do in practice, but those are the CDC guidelines. And obviously, you know, that's not how risk works. Coronavirus has not read the CDC guidance and doesn't care. So we can do better than this by combining these 3 factors together and then placing a threshold on actual risk of being infected, rather than, you know, following an algorithm that's partly there because it's easy to write down and easy to train manual contact tracers to do. So, you know, but these are still the important 3 risk factors. And I'd say of these, the most important is duration, but the least important is 6 feet. The second most important is what day it happens on. So we spent a long time reading all available evidence, and it supported a 10-fold difference in risk as a function of days since symptom onset. And I want to sort of point out that this 2 days before symptoms start business is based on this paper by Hay et al. That was debunked. They had a bug in their code. They accidentally truncated their data set and didn't, you know, had deleted the data that stemmed from other transmissions. There is better data out there right now. We originally went more with exposure science data and less with epidemiology data, which didn't seem to fit. But since then, you know, Ferretti et al. Has redone the epidemiology with, you know, with all available data, Hay et al.'s data without the truncation and everyone else's data, and it is completely compatible with what we'd already figured out from the exposure science. And 2 days is not early enough if you're going to capture all the risk. 2 days before is like only 3 days after. It's as though you truncated there. And then, you know, at some point, you're really not achieving much if you go all the way out. So there's a massive difference in risk here, far more than Bluetooth tells you, that people's apps have ignored, and are not ours. But I also just, you know, some people are sending out notifications for the last 14 days, in contrast to aren't using symptom onset at all. And you might literally be sending out something for a day somebody wasn't even infected, let alone infectious. So that's another issue. So there's massive risk information in timing. So that's one thing we can do. So what we do is we take this infectiousness, and already in version 1, we were using a method where that Google and Apple have now sort of promoted for version 2, which is to take the take the duration, because dose gives you risk. There is a close relationship between dose and risk that goes back to the 16th century in terms of scientific advances. And then sort of, to me, almost as an afterthought, oh yeah, and you can weight the time depending on how good the Bluetooth signal is. The most important thing about Bluetooth is it tells you that they were anywhere near each other at all. So we quantified how important each factor is. So Bluetooth is the worst of the 3. Bluetooth, it's a terrible measure of distance, especially in the real world and even in the laboratory. And distance is a terrible measure of dose because it's an airborne disease and it doesn't obey nice, clean distance relationships. Dose is, of course, proportional to time. 14 minutes, 16 minutes, they are extremely similar in terms of risk. And then infectiousness, is, varies tenfold. So that's the same differences between 15 minutes and 2.5 hours of contact. So what's been frustrating to me in implementing this knowledge is that in version 1 of Google Apple's system, we were not given access to duration in a meaningful way. It was capped at 30 minutes. And in fact, in version 2, we were using these 6 infectiousness levels I showed you on the slide, and they've restricted them down to only 2 levels, and then they've further restricted how we can use them. And when I complain to this, to Google and Apple, their response is, well, the other public health authorities say it's not a problem. But I know other public health authorities have issued exposure notifications for days that predate the infection date of the case. So there is an interdisciplinary issue going on here where communication is not happening from the latest science on how COVID is transmitted into the app development world. And it would be a very different talk for me to talk about the sociological reasons for this. But something I'd like to say to all of you is, firstly, please do use a better risk model. And secondly, please tell Google and Apple that you want a better risk model, because the reason we are limited in risk model options is because we haven't been asking for it. So risk models can get better than this. So yeah, what we parameterized and what we launched with in Arizona is basing infectiousness quantitatively on the time relative to symptom onset, which is the approach to a limited degree that Google and Apple are now pushing. But there are other factors that affect infectiousness, and I'll just tell you about one, which is incubation time. Sometimes we know when somebody was infected, and we know, did this person have a 3-day incubation period? Did this people have a 10-day incubation period? There is variation in the incubation periods. Here is a distribution of estimated distribution of incubation periods, and sort of this is the basis of the 14-day quarantine, is that most incubation periods, but not all of them, will be over by then. And what I worked with Luca Ferretti and the Oxford group on was quantifying whether this mattered and what the profile of infectiousness was for individuals with different incubation periods. And the answer was, yeah, it matters. If you sort of line them all up around symptom onset here, individuals with a longer incubation period are infectious for longer. So if you have information about incubation period and you're not collecting it, you're not using it, you're not going to be sending out exposure notifications for dates in which these people are extremely infectious. If you know the incubation period was short and you send it out, as you would for any average individual, you're going to be unnecessarily notifying people who had no danger of being infectious because they weren't barely even infected so far. So yeah, so it's interesting. It's also interesting that just from a biology perspective, that the decline is the same in all cases. Absolutely no support for different models, but there's strong support for different models of transmission risk prior to symptom onset. So yeah, and so just to sort of briefly summarize the methods here, this is just taking every single transmitter receiver pair that's been well documented with all the necessary information and just maximum likelihood fitting all kinds of transmission models to it and seeing what the best fits are. Yeah, so a lot of the work that we had to do when, I've told you that the thing I believe the least in the aspects of risk we have access to is the Bluetooth attenuation signal strength. But it's also the aspect that I think has achieved the most attention, had the most attention, including by us. And that's because it's the least known one. When we were just setting infectiousness, all we had to do was read the literature and okay, done now. But for the Bluetooth, we had to go and do experiments. And I was extremely lucky to connect to Amanda Wilson, who was a PhD student at the University of Arizona, whose specialty is quantitative microbial risk assessment. And I think everyone here needs to know that there is a field called quantitative microbial risk assessment, and they really should be involved. So their approach to pretty much everything, as I could make out, is a Monte Carlo sampling approach. And that's what we did. So we took data under not lab conditions, under deliberately messy real world conditions on real people's phones, on real scenarios, in bags, in pockets, whatever, trying to do a distribution of realistic conditions. And then while the data was generated as attenuation as a function of distance, what we did is we sampled it as distance as a function of attenuation. What are the range of, what's the probability distribution of distances that's compatible with that attenuation? And then for the distance infection risk relationship, we did a model. And that model was a Gaussian plume that somebody breathes out. You know, we're very focused on the face-to-face interaction. Somebody is breathing, they're creating their own wind. The wind conditions aren't completely stable, but those viral particles are coming out in a plume. And, you know, you can see that 6 feet's not that important. What's really important is the angle. You know, yeah, I mean, I think the picture really shows how Gaussian plumes behave. So the main information in our view in distance is what distance tells us about human behavior. You know, a study showed that, you know, in some Chinese grad student office, the average distance, interpersonal distance between people who are having a conversation was 0.81 meters. You know, we don't like to stand that close to people if we're not interacting with them. And we do like to stand that close to people if we are interacting with them. So we basically made the assumption that, you know, a distance of less than 1 meter was important, not because of the shape of the plume, but because it indicated the angle of the plume that you're face to face. And if you're further, then it was a random angle, which means, you know, you're not too likely to be hit by the plume. Just some mathematical quirks. The exhalation rate actually cancels out because the exhalation creates the wind as well as creating the speed of dispersion out. But, you know, how big the mouth is does come out in the math. And then, you know, sample the air conditions. So basically Monte Carlo approach, sample everything. And then sample the inhalation rate too, because obviously that makes a big difference. And Kevin Murphy at Google has since taken our code and interpolated, and I think there's a risk tool coming out that will sort of give you, you know, the ability to fiddle with this. But, you know, essentially, for those of you who like equations, this is the equation for a Gaussian plume, and you can see the mouth cross-section appear, the shedding rate appear, the degree of stability in the wind conditions appear, and you know, and essentially this angle is all important, and we calculate our dose as the duration times the inhalation rate times the local concentration of viral particles from this equation. Yeah. So when you do that, when you put that curve together, what we see is if you're face to face, you get the top curve, and if you're not face to face, you get the bottom curve. And if we're saying that 1 meter indicates whether you're face to face or not, you can see that there's way more information. You know, Bluetooth is or distance. Sorry, not Bluetooth. Even if you perfectly knew distance, most of the risk information in distance is about whether people are face to face, not about, you know, something about the diffusion of virus. So that's the modeling portion that we did. For the measurement portion, as I said, you know, Bluetooth is noisy in the best of cases. The Google Apple system is not the best of cases. And so basically we just did everything: indoor, outdoor, phones in pockets, phones in bags, like a real mess. We also did conditions that posed no risk at all, like being on the other side of a wall, so you're not in a shared airspace. It was not an ideal thing. This was research cobbled together at pandemic speed in large interdisciplinary teams, so there were some mistakes made. But we did do a lot of rebalancing of the data set after the fact to be sort of in accord with what crowd modelers and so on were telling us about what a realistic distribution of scenarios would be. We actually did these experiments with a GAEN app, and that gave access only, of course, to time inside 3 bins of attenuation. So we had to make a test version of that app under developer privileges to call the API many times with different attenuation thresholds to get down to 3 dB resolution, because we wanted to see, you know, how this was going to work under any mistakes that Google and Apple had made, all included in the measurements. And yeah, and then at the end of all this, back to the Monte Carlo sampling, we pick, you know, an attenuation range that we're interested in, and we sample a data point from our rebalanced data set that's compatible with that attenuation measure. And then that's either a risk of 0 if it was from one of the scenarios on the other side of the wall, or it's a risk from our Gaussian plume model. And then we chose thresholds, and our aim here was to maximize the amount of information about risk. So we basically maximized this function and chose, for the 2-threshold model of GAEN, we chose these thresholds. And this is a now out-of-date figure that I have from Google with some concept of theirs of the attenuation distance relationship that I don't subscribe to, but Arizona's picks are in black. And I just really want to point out that other people's picks may have changed a little since the slide was made, but they're much closer together. Other people were focused, believed that the design specification was 1.5 meters, or believed that the design specification was 2 meters. And we believe that the design specification is to maximize the amount of information about infection risk. And so there's a lot of, if you're less than 50 dB, you know, there's a very good chance you're face-to-face, there's a lot of information, and there's still risk a long way out. When you do these experiments under real conditions, there are lots of exposures that have very high attenuations, and we get risk actually, you know, pretty much throughout the range. So we actually end up with some, it's kind of not important given how the 30-minute duration cap, but these were the weights that came out of our model. Fortunately, they're actually not out of line. I'm not sure where. I assume people mostly made up 1, 1/2, and 0 as a guess, but that's not crazy. But essentially we tried to, it's probably still a little exaggerated though, we tried to maximize the amount of risk difference. And even though we took much more extreme thresholds than other people, we still only got a 2.7-fold risk difference. So a reminder that we've got 10-fold difference in infectiousness, well documented, 10-fold difference just between 15 minutes and 2.5 hours. And of course, you know, in the real world, differences can be larger than that. And that's so clear that it doesn't even need to be documented. That's self-evident. And, you know, only 2.7-fold in Bluetooth. So, you know, just to really emphasize that so much effort on the Bluetooth side, it's really not that important. We also did some beta testing where, you know, we used different weights and you know, it all came out the same. You know, the precision recall curves were basically identical. So, you know, just don't get hung up on that, you know, focus on the things that make the most difference. So we were trying, you know, to move into units of probability because there's a lot you can do with probabilities. So we fed dose through a dose response curve. It's actually expected dose, but we did some investigation of that and I think we're satisfied with the results. And we just roughly calibrated it. And so just for those of you who are app developers who aren't calibrated with the contact tracing literature, even if you are the household contact of somebody and extremely unprotected, your infection probability is only about 30%. Most people with COVID give the disease to nobody. If you are somebody who was contacted by manual contact tracing in somewhere where it's really thorough, like Taiwan or South Korea, you're only about 1% likely to be infected. So the infection risks are way lower than people think they are. Anyway, so we took this 30%, we just said, let's call that 8 hours of strong signal. And we used that to sort of just put it into units that made sense to us, which are very approximate infection risks. So this is a summary of our, basically what's happening. On the transmitter's phone, we're asking the questions. This is version 1, not version 2. We were already asking, are you symptomatic or asymptomatic? When did your symptoms start? When did you get tested? Do you know when you were exposed? We can ask any number of questions to come up with an infectiousness value. And then we use these weighted sum of durations to get dose, and from that to get infection risk. And sort of all our work behind the scenes was this data, was this Monte Carlo model that got these weights, and then this calibration that does this conversion between dose and infection risk. And when we have infection risk, we found that convenient to think with in terms of setting a threshold, which in the COVID Watch app can be done regionally. So it's not, the University of Arizona and Northern Arizona University are both using the app, and they don't have to set the same threshold. We're about to launch in Bermuda. Bermuda has way fewer cases than Arizona. They probably want a lower threshold. And so, it's a very tunable knob that there's just a number. And so we launched with an extremely high threshold within the resolution of what the GAEN would allow. And basically all the shaded parts are because version 1 doesn't allow us to record something that would be sufficient to trigger an exposure. And then, we're about to move, actually, we have great news from our campus. From having a terrible outbreak, we now have hardly any cases at all. And so we're moving to a different threshold, and this essentially, our formulae allow us to calculate risk in a consistent way, and then and tune it to the conditions on the ground, not to overwhelm systems, not to unnecessarily alarm people, and so on. So how do we know that our risk level, that anything we do works? And I think the answer to this is super important. We don't. Nobody does. Unless that's I think one of the terrible things about these risk models is there's no feedback that you're getting it wrong. Most metrics, every metric I've seen released by any group has sort of been focused on usage statistics of one sort or another, with varying degrees of how far through the pipeline of usage they're going. But unless you're actually tracking individual exposure details paired to subsequent test status, you don't actually know if, you know that exposure notifications are going out, you don't know that they're going to the right people. If you get your risk model wrong, you're going to miss a whole bunch of infections, and you're going to be sending out notifications to way too many uninfected people. I mean, remember, even if you're doing a good job, only 1% of them might be infected. If you're doing a bad job, you are sending notifications to people who really, if maybe they're infected because lots of people are infected in the region they're living, but the chance that they're infected because of the exposure that you tracked is not there because that person wasn't even infectious. So, people have been claiming, for example, in Switzerland, that if you can show that some people test positive after receiving an exposure notification, then it must be doing its job. Now, I mean, it is useful if exposure notifications are driving people to testing who wouldn't otherwise go to testing. But, for context, we had a terrible outbreak on our campus. And at the height of that outbreak, you could test students, asymptomatic students at random, and 9% of them would test positive. So, I mean, I could be declaring victory about all the people who received exposure notifications and then tested positive, but I would have got the same thing if I tested people without exposure notifications. This is outside any conceivable resolution of risk possible under GAEN version 1. So these success metrics are great, but they are not validations that you are targeting testing resources or quarantine recommendations better than random when you have high outbreak levels. That's obviously going to change some in version 2 of GAEN. But this is our experience with rollout to date. And then the next point I want to make is, even if you have like an ideal risk model, it isn't going to achieve anything to stop the epidemic unless people actually do quarantine when asked. And that's the next thing I want to talk about, because I think one of the reasons, I mean, quarantining for 14 days is really hard for most people. It causes a lot of harm. You know, they need the money. They, you know, haven't got groceries. They have relatives to take care of. People, you know, we've all read at this point plenty of accounts of people not even complying with isolation. Certainly at the highest levels of the US government, we have failures to comply with both isolation and quarantine standards. Yeah, that people have to quarantine, and my hunch here is if we ask less of people to quarantine, they might be more likely to do it, because my suspicion is that right now they're not doing it very much, which means that the best app in the world, technically, and risk model and whatever, isn't actually going to have a high impact. And that's, you know, the lack of ability to get people to quarantine. So one of the things I want to do is I basically want to make quarantine shorter. So one way to think about this is that we had this, we replaced these 3 binaries, and instead of like asking yes, no, yes, no, yes, no, we integrated them and then treated infection risk consistently. But, you know, 14 days of quarantine is another binary. Is it less than or more than 14 days? And if you're talking about the probability of infection, like all probabilities, it is a conditional probability. If you haven't had symptoms for first 5 days, then the probability that you will get them goes down. It's a little more complicated for COVID because there are also asymptomatic infections. So, you know, quarantine actually might need, if you don't have testing available, quarantine needs to wait until infectiousness is over, not just for symptom onset to be over. CDC considers, you know, people to be infectious for 10 days following symptom onset. And I sort of want to say that, you know, people sort of say, oh, 14 days is conservative. Well, no, it's just another quantitative factor. The risk of current or future infectiousness drops about 11-fold, you know, if we recall, in comparison to the other factors we were previously discussing. It's just one more risk factor, which is how many days have gone by without having symptoms. So this is specifically assuming 20% asymptomatic rate. So a lot of people think that 14 days makes it safe. And originally 14 days wasn't bad because everyone in quarantine was getting tested. Everyone in quarantine is not getting tested. You know, quarantine, you know, some people are doing 14 days quarantine means 14 days quarantine. Some people are saying 14 day quarantine means 14 days plus a negative test towards the end. Sometimes there'd be a test, but it won't be towards the end. So if there was a long incubation period, you were not cleared. The point is, it's all risk management and it's all quantitative. And if you picked 13 days, it would be an 8-fold reduction. If you picked 15 days, it would be an 18-fold reduction. You know, this is all risk management. So one thing we described in this preprint and is basing quarantine on consistent treatment of risk, specifically the conditional probability of future or ongoing infection. And that's a function of all the initial risk, but also how long without symptoms, any negative test results. And if you were willing to collect personal information in particular age, then you could also modify what the fraction of asymptomatic cases are in that group. And so that risk threshold would then set not just who quarantines, but also for how long. So what I'm showing here of a 0.13% threshold does correspond to a 14-day quarantine for an individual who is infected with this initial probability here, typical of well-resourced manual contact tracing. So that threshold sort of roughly corresponds to our current risk tolerances. So, you know, that would, but if you were to use a higher risk tolerance, for example, you know, you have a huge outbreak, then you might decide to limit the recommendation to 7 days where, you know, for them to fall below that threshold and you still get most of the good out of that. If you go to 0.13, it's not that you're quarantining everyone for 14 days, you know, you're also catching people with much lower thresholds, and this one here would get a 5-day quarantine. And so, you know, you variable length quarantine. And when you use something like this, these are 2 comparisons that have probably sort of fairly comparable tolerances for risk, but you get way more good per day of quarantine recommended when you do variable quarantine. So in practice, virtually nobody gets more than 14 days. The very, very highest risk exposure here gets a 15-day quarantine. Most of the others that were getting 14-day quarantines before are getting 14, 13, 9, 10, and so, oops. But what's happening is that you're capturing a much wider range of people for short quarantines. You're probably recommending about the same amount of quarantine as before, but it's much more equitably distributed, and it's achieving more in terms of epidemic reduction if it was followed. And I believe it's also likely to increase compliance. So yeah, to point out again that, if you have, like we do, young and healthy students, then you have a larger asymptomatic fraction, and that can change the, in the absence of testing, that is. We're testing, so it's not so much an issue for us, but in the absence of testing, that will change the quarantine durations. And so, why not do this? And I can tell you about my experiences with public health. So public health came back and said, there's a problem because we're conflicting with the 14-day messaging, and it's very important to stick to that 14-day messaging. And, well, but you can actually do better than that. Like, one option is not to tell people what day they were exposed, and just tell them what their risk is and when they should quarantine with. And, so that is both preserves any, it eliminates any conflict with 14-day messaging. And it also preserves privacy much better because people don't actually know which day they're exposed. So there is a solution completely available for that. And if a manual contact tracer calls too for a known exposure, which has not generally been our experience, or at least not in Arizona, it may not even be for the same exposure. Yeah, and then we can't do that, in more complicated cases if we want to use negative tests. So we're still working on exactly how to incorporate negative tests out, but this is just a simple example for illustration. We show Bayes' theorem being used with a 30% false negative rate, and you can see that it reduces this very long quarantine from 16 days to 13 days, and there are better ways of doing this. If we do this, of course, then we can't also disguise the fact that quarantine length is flexible. And so, this is the question for public health. Does public health want to be adamant that 14 days means 14 days with or without testing, which is something that does not treat risk consistently? Or does public health want to align incentives in ways that maximize compliance and the public good, which can mean a bit more flexibility in order to actually achieve the goal of people, not passing the disease on? So essentially, I am an advocate for risk management and this is not how public health thinks, but it's certainly, for example, how the financial world thinks. Anyone who doesn't treat, risk consistently has this proved to them by being the dumb money, and having bets placed against them. I think that when we're betting on people's lives, we should use the cutting edge insights of people who bet with money. And we need to recognize the really strong ethical component to this. Quarantine really does impose harm, and we have a responsibility when we're imposing that harm to get the most benefit from disease transmission we can per day of quarantine that we recommend. So we are working on a new algorithm, not the one I've shown. We're not quite ready to release it, but it does a much better job, I think, at really calculating which are the most critical days to stay home, so we can communicate to somebody. If you can only stay home one day, make it this day. If you can only stay home 3 days, make it these 3 days. And that we give this information and we empower users whose lives are curtailed. If governments are not stepping in within, to support them in their quarantine and to incentivize their quarantine and to make them willing to do it, you know, if we're asking people to sacrifice for the greater good, we should also be willing to share the information with them so that they can make their own choices and do so in the most effective manner. And so that's something that'll be out fairly soon. And, you know, just on a practical matter, of course, we don't want so many quarantine recommendations that further cause people to ignore them. And treating risk consistently is really useful because it basically gives you a knob and, you know, you can tweak it depending on what's going on. So I have a huge list of people to thank. This is massive interdisciplinary work, but most of all, I would like to thank Amanda Wilson, who was finishing off her PhD in quantitative microbial risk assessment. She's now a postdoc at Utah, and she was absolutely pivotal in doing, you know, this work. And also especially James Petrie at WeHealth, who's done a lot of the work that I'm alluding to without fully discussing in this talk, and who's going to make these algorithms so much better in the future. And for those who don't know him, he was sort of behind the TCN protocol, and, you know, maybe one of the, you know, for all I know, may have been the first person in the world to fully grasp how privacy preserving protocols can work. And he's just fabulous to work with. And then all these other people, and I cannot list what they've all done, but they've all been fabulous. You know, huge interdisciplinary teams are needed to make progress on any of this. So thank you all.